faculties and virtual delegates who have joined us from every part of the country. As Dr. M.B. Agarwal was saying, with generics of oral azacitidine and midostaurin getting available in India, discussions today will have a significant impact on the clinical practice of AML in India. A special welcome to Professor Dr. M.B. Agarwal, who has been at the forefront in driving scientific initiatives over years with only goal of improving hematology care in India. While he is spearheading these scientific symposium with never-ending energy, his life has also inspired so many young clinicians to take up hematology practice in India. He is a clinician par excellence, as we know, and teacher and guide for so many clinicians in India. I have the privilege today to introduce Professor Dr. M.B. Agarwal. Sir is Professor and Head Department of Hematology, Bombay Hospital Institute of Medical Sciences, Mumbai, and also consultant at Lilavati Hospital and Breach Candy Hospital. With that, sir, I will request you to take the program forward from here. Over to you, sir.
Thank you, Mr. Ashish. I'll just share my screen. So, good evening, friends. Today, our guest speaker is Dr. Naval Dawa from Houston, Texas. He will be lecturing us on acute myeloblastic leukemia. This webinar is brought to you by Mumbai Hematology Group. It is supported by Zydus and managed by Mice Ideas. I'm extremely grateful to Mr. Ashish Kumar and his team from Zydus, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, and of course, our guest speaker, Dr. Naval Dawa from MD Anderson, Houston, Texas. All our discussants, who are themselves very eminent hematologists and medical oncologists across India, new participants from all over the world for sparing your Saturday evening or morning or afternoon, wherever you are. I must inform Dr. Naval Dawa that we have almost 400 plus registrations, 1/3 students, 2/3 consultants, and almost about 100 of these from all over the world outside India. The discussants are from Delhi, Ahmedabad, Chennai, Bangalore, Mangalore, Kochi, Kanpur, and Surat. So we have Dr. Pravas Mishra, Director of Hematology in BMT, Max Hospitals, New Delhi. Dr. Ranjit Kumar Sahu, Associate Professor, Department of Medical Oncology, AIMS, Delhi. Bhavin Shah, Medical Oncologist, Director, Hemato-Oncology Clinic, Vedanta, Ahmedabad. Dr. Kishore Kumar from Miyot International Hospitals, Chennai. Dr. Anup P. from Apollo Hospitals, Bangalore. Dr. Prashant Bhatt from KMC Hospital, Mangalore. Dr. Ramaswamy from Esther MedCity, Kochi. Dr. Neeraj Siddharthan from Amrita Institute, Kochi. Dr. Vikas Talreja from Regency Hospital, Kanpur. And Dr. Hasmukh Balar from Mahavir Hospital, Surat. It's my proud privilege to introduce Dr. Naval Dawa. He doesn't require introduction. He has been our guest at multiple occasions. He has been a guest faculty for these webinars during last 1.5 years, once again at a number of occasions. Not only that, I know that all of you look at him when you have a difficulty in the field of AML, and he has been very prompt in answering and solving the solutions. So to complete the formality, he's Associate Professor and Director, Leukemia Research Alliance Program, Department of Leukemia, MD Anderson. Clinical investigator, focus on molecular and immunotherapies in AML and other myeloid diseases. PI for over 25 ongoing institutional, national, international clinical trials. These trials focus on developing personalized therapy, targeting specific mutations or immune pathways in patients with AML and evaluating various kinds of novel combinations of targeted immune and cytotoxic agents and identifying and overcoming the mechanism of resistance. It's published over 260 peer-reviewed research articles, and this number may be a bit old. He is on editorial board of numerous hematology journals, is co-director of the MDACC Hem-Onc Fellowship Leukemia Rotation, and his mentored various, the large number of fellows and junior faculty. I invite him to deliver his talk on AML, and I'm sure that all of you will update your knowledge and benefit from his talk. Thank you so much.
Thank you very much, Dr. Agarwal, and all the colleagues, and always a pleasure to give this presentation. Let me start by sharing the screen here and make sure that you can see it. Let's see here. always a bit tricky.
We can see it.
You can see it, okay. And it's in the full slideshow mode?
Not yet.
Okay, let me see here. Play from beginning. And swap. Okay, now is it in full?
Perfect.
Okay, yeah, so thank you all very much. And yeah, it's been a long time that I've been back to India. Usually I go 2-3 times a year, either for meetings with Dr. Agarwal or other colleagues, and then to visit parents. But with COVID, it's been a while, so I'm a little sad about that. But hopefully next year we can all meet up, whether it's in India or whether you all come to the US for other meetings. But the good part is that I think, the leukemia research has continued in full swing. We really are fortunate and happy through efforts of many, many cooperative groups, research alliances, MD Anderson, that the clinical trials have all continued on full swing after maybe a 5-6 month slowdown in the initial period, and drugs are still moving forward. So that is the good thing. And I think, of course, most importantly, we continue to make a lot of progress. And also, I think, as Dr. Agarwal mentioned, 400 participants. Of course, we all hate COVID and what it's done to the world, but I think there is a silver lining that we have now really maximized our virtual potential and international collaboration. We talked about this for decades, but through COVID, I've been on 5 meetings this week, 1 Europe, 1 Australia, 1 India, 1 US, and all of them, we had a huge number of participants, not only from that country, but from surrounding countries. So this is actually great because the dissemination of knowledge has really been maximized. And hopefully even after COVID, we will continue to be able to use these virtual platforms and continue to spread knowledge and get drugs out quicker to all the regions of the world. So with that, I'm going to move on to the presentation. Pretty broad topic, AML, and I will focus more, as Dr. Agarwal said, on maintenance and some of the commercially available drugs. I will mention what is exciting and upcoming because I think that's important for completeness sake, but we'll spend more time on the approved drugs and especially those that are available in India. These are my research and consultancy disclosures. So, I always like to show this timeline and it always gets outdated like this one is. I probably needed to use the more recent slide, but there were 8, actually now 9 drugs approved in the United States as of early 2021, the most recent being the oral azacitidine or CC486 that I will talk about later, which is the first maintenance therapy in acute myeloid leukemia. But of course, there are all these other drugs that includes the FLT3 inhibitors, IDH inhibitors, and then Venetoclax, which, I personally, as well as all of us at MD Anderson, think is probably the singular most important impactful drug in AML and maybe in other diseases, CLL, potentially in ALL in the future, and then other novel combinations of chemotherapy such as the CPX and Glastigib. One thing we are really seeing is we have truly moved into a personalized era of treatment. And this is, again, something that for a few decades, from the 80s with the advent of PCR and NGS was being discussed. And of course, CML was the poster child of this. The true targeted therapy breakthrough survival went from 20% in the interferon era to 95% in the most recent update with multiple TKIs available. So we hope that this would be replicated. Unfortunately, we found that other leukemias and lymphomas were not as singularly driven by one aberration or mutation as CML was. And so it's been more challenging, but I think we're getting there. And as you can see now, there are multiple targets. FLT3, IDH are the established ones in the US, NPM1 and TP53 mutations that are upcoming drugs. And there's also another group called MLL rearrangement, for which there's a group of drug called Menin inhibitors that I think you will hear a lot about at this year's ASH, and then next year, already 4 Menin inhibitors in trials. And some of the data has been sent out in press release. And I will say that these drugs are very, very powerful for MLL rearranged, giving us up to 60% single agent responses. So we think this is the next targeted therapy breakthrough. And then RAS mutations, we don't yet have a clear drug that has shown efficacy, but it is an important pathway with efforts to target it because it's become a common pathway of resistance that we're seeing more and more after FLT3 inhibitor, after IDH inhibitor, after the Venetoclax. So emergent RAS mutations are becoming a common problem that we need to target. And then TP53 I'll talk about with CD47 and other therapies. I always like to have 2 slides on APL. For all the progress we've made in other types of AML, the most curative And actually, maybe one could argue even better than CML, the true poster child of what we would like to achieve in leukemia therapy is APL, because this is a time-limited, finite, non-chemotherapy treatment giving us 96 to 97% long-term cure rates with very, very low toxicity and long-term comorbidity and zero transplant. So I think that's our goal for other therapies. And as you know, this has been published by many groups. MD Anderson was actually the first to do the arsenic in the late 1990s with the late Eli Esty, as some of you may have heard. Eli actually passed away 2 weeks ago. This was very, very sad. He was one of the champions of not only this, but many other breakthroughs in AML, both at his time at MD Anderson and at the Fred Hutch. But himself, Egop Kantarjan and Farhad Ravandi started this, and then the Italian group, Lococo, took it forward into randomized studies. And as you know, this was the result showing 96% 5-year survival in large phase 3 randomized study of 300 patients, confirming arsenic as a great standard. And the hope is we may be able to get here in the future. And there are some regimens that are starting to get to this. You will hear about blinaponatinib in ALL when you hear from ALL speakers. This is something at MD Anderson we're championing, and the data will be at ASH. And this is, again, maybe another chemotherapy-free regimen in ALL that could give us similar results. So that's the hope eventually to get there for other groups. But for now, we don't have those kind of approaches yet for most of the general AMLs. So what is our approach today for a non-APL, a young AML patient at MD Anderson? So we definitely are looking for underlying mutations. That includes FLT3, that includes core binding factor, because we do separate therapies for them. We do look for MDS-related cytogenetic changes, deletion 5, 7, 7q, 17, or people with a history of therapy-related AML or AML from a prior MDS, and we will consider CPX-like drugs there. And then for all the others, our backbone is now FLAG-IDA or CLIA with Venetoclax, and I will talk to you about that. As you know, both of those were published recently, one in JCO, one in Lancet Hematology. But it's more about the total therapy. So induction is part of the regimen, the consolidation. Transplant is actually very much so there. So unlike ALL, where the transplant rates have gone down quite a bit at MD Anderson and other centers in the US, especially in Philadelphia positive, but even in Philadelphia negative because of moving Eno and Blina up front and ponatinib. In AML, in fact, what we're seeing is we're getting deeper remissions. However, we don't have yet the confidence that these will be durable. So in fact, we're getting more people today to stem cell transplant in AML than we did 10 years ago. And then maintenance, whether it's pre-transplant in patients who cannot go to transplant because of age, comorbidities, no donor, finances, or post-transplant maintenance, for which data is also emerging, are now the standard. So it's really moving to a myeloma paradigm, as you will see more and more as these slides evolve, to a total therapy where you don't stop after induction, consolidation, or even transplant. You continue with maintenance. And the hope is that these will start improving our survival over the long term. So this is, so I'm going to split this discussion into kind of different sections based on molecular targets and approaches. So FLT3 is, of course, probably the one where the most progress has been made as a molecular group. You all know the multiple FLT3 inhibitors that are in development or approved. Midostaurin is the only one today approved in the frontline setting and is being used quite extensively in US, Europe, and India, and the rest of the world. But other FLT3 inhibitors, gilteritinib, quizartinib specifically, which are very powerful second generation specific and well-tolerated drugs, are being evaluated in randomized phase 3 studies in the frontline setting. In fact, the quizartinib randomized phase 3 study in the frontline setting is expected any day now, maybe within the next month or so. We are hoping to hear about the top line results. And given all our experience with it, we really think that it should be positive. So we will wait and see gilteritinib probably next year. But for now, the only one in the frontline setting approved is midostaurin. It's important to know that there are differences in the type 1 and type 2 FLT3 inhibitors, not just academic differences, but actual practical differences. So if you have a patient with a TKD or D835 mutation, as some like to call it, the type 1 inhibitors, mainly gilteritinib, midostaurin, are the only ones that work. The type 1 inhibitors like sorafenib and quizartinib will not work in a patient with TKD D835. So we would never give them to a patient who has TKD D835, even if they have it with an ITD. We would prefer the gilteritinib or midostaurin. And this is also important because what we see is people who have ITD mutations, when we treat them with sorafenib, quizartinib, a common mechanism of resistance over time is emergence of a on-target TKD mutation. On the other hand, when you treat ITD or TKD patients with gilteritinib, the emergent mechanism of resistance is not on target in the FLT3, but it's off target through parallel mutations in other pro-survival pathways like RAS-MAP kinase, BCR-ABL, and others. And we've published on this, especially the BCR-ABL is a practical one to remember. If you're seeing somebody failing a FLT3 inhibitor, I would recommend a quick check with the FISH or PCR for BCR-ABL. It's not common, about 5% people have it, but of course, this could give you a very nice therapeutic path with imatinib, dasatinib, ponatinib, which we've actually used and published case series of patients who've benefited. So think about BCR-ABL post-FLT3. So the other, of course, the frontline data, everybody's seen this slide probably dozens of times, published in New England, updates have been published. Midostaurin versus placebo with intensive chemotherapy backbone was first of those 9 drugs to be approved in the last 4 years. And you can see that the primary endpoint was met with survival. You can also see that the survival benefit is not dramatic. It's there. It was a proof of concept. The drug could be delivered. It was safe. It improved remission rates and it improved survival. But we think this is really the beginning. You know, we would, of course, 10 years from now want to be at a much better survival benefit. And maybe the second generation FLT3 inhibitors added to intensive chemo with transplant, with post-transplant maintenance will be able to get us there. And to that point, we do see that from this RATIFY study, although this is a retrospective subset analysis, this was not powered, but when we go back and look at the different subsets, we do see that those people who got the optimal approach, FLT3 identified early on, midostaurin added early on, induction 14 days, consolidation 14 days, transplant usually after first consolidation or second, and then post-transplant maintenance if possible. And you see those who got transplant in CR1, that survival curve is really where we would like our patients to be on today, which is closer to 65, 70% at 4 years. And in fact, that does not yet account for the post-transplant maintenance because that was done only on a subset of these patients. And I think that could bring these people up higher. You'll see data coming out in the next 6 to 8 months from our group, which basically is going to show that in large numbers of patients, more than 2,000 patients that we've analyzed, FLT3 no longer seems to be an adverse molecular marker. This is very similar to the story of Philadelphia positive ALL, for those who know it from the 1990s to the early 2000s, with the advent of imatinib, dasatinib, ponatinib. Today, Philadelphia positive ALL not only is considered intermediate, but with blinaponatinib, in fact, when I'm on rounds and I see a person, I'm hoping, and this has happened many times in the last month, that they're Philadelphia positive ALL, because I can give them blinaponatinib and they can have 100% remission. And you'll see this data at ASH with MRD clearance in many of them. And that this could be a favorable subset. And I think we're getting there with FLT3. It already seems to be, at least in our experience with the FLT3 inhibitors and transplant, moving into an intermediate population, not doing worse than the general. And hopefully when gilteritinib and others move up front and maintenance becomes a standard, I would not be surprised 5 years from now if we're actually hoping our patient is FLT3 mutated because we have such good drugs to give them. So moving to the next generation FLT3 inhibitors, these are quizartinib, gilteritinib. Both are excellent drugs. A lot of people compare them. I really don't think so. I think this is very much like the story of dasatinib and nilotinib, where, you know, these are 2 drugs, very effective, pretty much equally effective, both preclinically and clinically. Response rates, as you see, a single agent are in the 50% range, which is quite fantastic for relapsed FLT3 AML if you think about it, because chemo, as you know, in both these studies, FLAG-IDA gave us a response rate of about 25%. So the oral single agent was doubling the response that you get with high dose combination chemo. Some differences in the trial, but really I think where this is going to go is again going to be in selecting the right drug for the right patient. So patients who have RAS mutation, gilteritinib does not work as well, I would probably go for a quizartinib regimen. Those who have a TKD, quizartinib doesn't work, I would go to gilteritinib. And I think frontline is really where we'll see the best benefit with these drugs as these are going on. So I think they both have high value and there's no real competition per se, but selection more important, and eventually sequencing, because we will see that people who are treated with quizartinib after some time will get a TKD, then you bring in a gilteritinib regimen, then they may progress, then you bring in other, and trials are actually being designed to this kind of approach of what we call sequential therapy in FLT3 inhibitors. So frontline approaches, you know, I did mention we're excited about gilteritinib, quizartinib, crenolinib, and this is the reason, as you can see, the remission rates, at least that we have seen with these, when you compare to the remission rates of Ratify, seem much, much higher. Now, of course, Ratify was a randomized phase 3 global study, and these are more multi-center, but within the US. So we have to confirm it, and all 3 of these are now in randomized phase 3s. Quizartinib 7+3 versus 7+3 placebo will be the first one because it started the earliest, and then the crenolinib 7+3, gilteritinib 7+3 versus Mido 7+3 are ongoing. But I think it's likely that these will come out to be replacements in the future for the midostaurin. Maintenance, I know, is very important in India, and it's even better because sorafenib is available. There have been 2 large phase 2, relatively large phase 2 studies published showing the clear benefit, whether it was EFS, OS, for maintenance sorafenib post-transplant in FLT3 mutated patient, irrespective of whether they got a FLT3 inhibitor with their previous therapy. There was a lot of discussion. In fact, I actually reviewed both these papers, the one for JCO and the one for Lancet Oncology, and we asked the authors to provide that data of people who got the FLT3 inhibitor before transplant. And in the paper from China, which is Lancet Oncology, they actually do include that. And the benefit was maintained even if they received FLT3 inhibitor during induction consolidation maintenance transplant, still post-transplant, the maintenance had a beneficial impact. So for us, these 2 data sets are very sufficient, and we are using maintenance. Our effort is to do in 100% of patients. Of course, there are some who have really bad GVHD issues, but I would say about 75% of the time, within about 3 months, and timing is important. You want to do it earlier than later because FLT3 can relapse. So the ideal time point is between 45 to 90 days. And I would say in about 3/4 of the patient, we're able to start it. Sometimes we start, most of the time we start low. We would start with maybe 200 BID or even 200 once a day, ramp the dose up. Now, we have moved to gilteritinib for maintenance, and it's really, really well tolerated. It's like a night and day compared to sorafenib. Sorafenib was a great drug, but it was difficult to deliver and a lot of dose interruption. With gilteritinib 80 in a maintenance setting, we're actually able to do it pretty much in everybody without issues. But of course, that's not yet on label. The trials are ongoing. And that brings us to this next trial that hopefully we'll hear about next year, which is the randomized study of gilteritinib versus placebo. This is the largest post-transplant maintenance study I'm aware of, close to 350 patients. And of course, if this shows a benefit, we'll get us global approval for gilteritinib. But again, our experience, which is not that small, we've treated probably about 20-25 patients with gilteritinib maintenance, putting together data post-transplant. It's been really, really well tolerated. And I see very, very few relapses actually. So touch wood, I think that gilteritinib would be a very nice post-transplant maintenance. What about IDH mutations? I'm not going to go over too much. I know it's not available in India, but Agile study, the phase 3 global study, was positive. So it will hopefully get global access in the next 1 to 2 years. So it may be one that does come into play in the future in India as well. So we know it's a smaller subset, 10 to 15%. We also know that IDH per se does not have a adverse prognostic value. But of course, if you can make something better, even if it's intermediate and we can make it favorable, that's still a benefit. Also important to note that especially in people from MPN to AML, and these are, as you know, the worst of the worst AMLs, we really look for IDH in these patients because if they have an IDH, which is quite common, up to 30% can have it, then we will go for either an IDH inhibitor or even for Venetoclax. And in fact, the only subset of MPN, PV or MF transformed to AML that seems to do reasonably well is those where we find IDH mutation, give them Venetoclax or IDH or IDH, and those people do go into remission, do well. All the others, as you know, are usually enriched with TP53, ASXL1, RUNX1, all these bad actors, and it's a pretty hard subset to treat. So look for the IDH and MPN transformed AML. That may give you a therapeutic angle for Venetoclax, which of course is available in India. But single agent IDH inhibitors is how these were approved in the US. As most things, they have to go through a single agent path. They had activity as single agent. You've seen this data by Dr. Denardo, Dr. Stein, and response rates are about 30-35%. Not bad as a single agent, extremely well tolerated drugs, even I think easier to tolerate than some of the FLT3 inhibitors, but median survival is only 10-11 months. So I think a reasonable approach if you're trying to prolong life, get some time, but really if you cannot give the patient a transplant, this is prolongation more than a true long-term durable curative impact. So how do we build on this? And as the train goes for all the other therapies, you'll hear, of course, the approach is move it frontline, combine it, double it or triple it, and see if we can really then maximize the potential of these drugs. And in ALL, again, they're about 8-10 years ahead of us, where this is what's happening with ENO moved up front, Blina moved up front. Now we're seeing really long cure rates. And also it has an economic argument, right? Some people use the reverse economic argument. They say, oh, these are really expensive drugs. But our group and Kantarja and myself, others, we say, if you're going to use Eno and Blina and you're going to spend $200,000, you really want to cure those patients. If you can cure 30% more, 40% more, that's a good investment. If you can improve your median from 6 to 9 months with Eno and Blina spending the same money in the salvage, I don't think that's a great economic argument. So our hope is you do it up front, you do it for a finite period, and you can really cure some of these people. We're seeing with the AZA IDH here, the response rates are quite good compared to IDH alone, and the CR rates were also better. Now, interestingly, in this study, the median survival was not improved. And that kind of brings us to another separate issue that's being discussed a lot with the FDA and among our investigator groups in the US, is that now with the advent of effective therapies in relapse, it's actually becoming harder to get OS benefits. So two large studies where we all would have bet our money they would have been positive, AZA enasidenib versus AZA, and AZA gilteritinib versus AZA placebo lacewing, were both negative. And both of those studies, the lacewing one that will be shown at ASH, show actually very dramatic improvements in CR, CRI, MRD, EFS, everything. But then the OS does not get improved. And what we start seeing is a lot of patients, when they relapse after AZA, we're getting AZA enasidenib alone or HMA-Venetoclax and being effectively salvaged. Or those who are failing AZA placebo on the lacewing study got gilteritinib or azacitidine or crenolinib or other things and got salvaged. So we may not be able to use OS as well because we have really effective salvages now, and maybe EFS is a new endpoint. And that actually is something you'll start seeing with some of the ongoing studies. In fact, the Agile phase 3 study of IDH inhibitor plus AZA versus AZA used EFS, and we know it's positive, and we'll get it approval in Europe and most of the world. So moving beyond that, which has always been our approach, is, well, AZA IDH is good and AZA Ven is good, but in the end, both of them, if you look at the 3-year survival, it's about 55 to 60%. It's not 90 to 100%. So can you improve that? And so this is the effort where we have started combining these drugs. Of course, when we combine them, there's a lot of, it's not a simple combination. There's a lot of modification. There's a prolonged dose evaluation period, adjustments for toxicity, growth factors. So it's still a work in progress. But as you can see, we are seeing what we were hoping, that the remission rates are now going to 90, 100%, as opposed to 60%, even with the combos, or 65%. And we're starting to see prolonged survival. So this data will mature and hopefully find a potential curative role. So this could be the ATRA arsenic for IDH, is what we're hoping, where AZA-Ven IDH, if it could truly give you 90% higher remission rates with MRD clearance, with 3-year survival of 80%, well, this could be very, very effective. So we have to wait and see. Now, moving to another subset, these are the core binding factor AML. I think everybody in India is quite familiar with this group in version 16.821. The key point I want to make is we do need to check for these. We do check for these 100% of our patients who come in. And in those patients, we go for gemtuzumab. That is the drug that has shown the clearest single agent efficacy benefit in core binding factor. As you can see, quite a clear EFS benefit in this one study from the alpha, but there was a very nice meta-analysis of different studies published by Dr. Hills, a statistician from UK, 3,300 patients in 5 randomized studies in Europe, US put together. And very nicely, he shows that the clearest benefit for gemtuzumab added to anthracycline cytarabine backbone is in the core binding factor in version 16.821. And even in the early 2000s, we could see that the addition of gemtuzumab was getting us close to 75, 80% survival. And I think today, with better regimens such as FLAG-IDA, gemtuzumab, and better transplant if needed, we are potentially able to benefit that. So our approach today is using FLAG as the backbone. The recent update was presented by Dr. Borthaker from our group at ASH, with now 160 or so patients enrolled. And with the FLAG gemtuzumab, we have a 5-year survival of about 83 to 84%. So really not as good as APL, of course, but probably the second best subset for AML. This is published and one can use this. We have started omitting the IDA, actually. We're just doing FLAG gemtuzumab because with the IDA it was getting quite myelosuppressive. And with that approach, induction consolidation, use of the GCSF. And the key here is using gemtuzumab only 1 dose with cycle 1, cycle 3, and cycle 5. and we use it only at 3 milligram per meter square. It's very important because if you use higher doses of gemtuzumab, you start running into problems with VOD. But at the 3 milligram per meter square given once, cycle 1, 3, and 5, as we published, it was well tolerated and did not have many problems. We don't transplant majority of these patients. I would say 80% of core binding we don't. The ones we do transplant are either relapse is relapse. And actually this has been published, Dr. Gantardi published this 8 years ago. When we look at relapse core binding and relapse everybody else, they almost do as bad. So once you relapse, you just have to treat them as relapse AML. It does not matter as much if they're core binding or not. But the other group is those who are PCR positive at the end of the planned 6 cycles. So if they are completed 6 cycles of induction consolidation flank gemtuzumab and are PCR positive above 0.1, confirmed on 2 readings 4 weeks apart, one, and is a very young patient, one could consider transplant. Now, we could also consider their maintenance that we'll talk about later, whether it's with the CC486 or whether it's with HMA-Venetoclax based approaches, but that data is still early. So that is a group where if you're PCR positive after 4 or 5 intensive therapy cycles, giving 2 or 3 gemtuzumab with those cycles, I think you could consider transplant. So now moving to another group, this is a group that kind of got carved out because of a drug. So we didn't really think of these people separately 6-7 years ago, but now because of CPX showing the benefit here, we do think of this group as a separate group. So this is the group that we call AML with MDS-related changes. And that includes 3 groups. So patients with MDS-related cytogenetic abnormalities. So this is a patient who just presents to you with AML, no history of chemo or prior hematological disease. You do the bone marrow, you do the cytogenetics, you find deletion 5 or 7 or 17 or inversion 3 or one of these things that the WHO lists as a MDS-associated cytogenetic change. And then the second group is people who have a known chemo or radiation for another malignancy, for a brain cancer, for lymphoma, for myeloma. We're seeing a lot of lymphoma, myeloma patients nowadays actually coming with a therapy-related AML. So that's called therapy-related AML. And then the third group is people who have a known MDS, maybe they're on growth factors, observation, HMA, and they progress to AML. So these 3 were included in this population of what we call AML from MDS-related changes. And the drug here, which I don't think is routinely available in India, maybe in the future it will be. I know it is expanding and they've started getting access in Taiwan and Japan, Australia, some regions. This is a CPX351. So it's not as cool as many of the other drugs that I'm talking about, FLT3, IDH, Venetoclax, immunotherapies. It's really a repackaged formulation of cytarabine, anthracycline, and liposomal effect. Now, even though it's not that cool, doesn't mean it's not that effective and we don't use it, because it does give much less mucositis, less hair loss, which is quite interesting. When you talk to patients, as physicians in AML, our focus is survival, survival, survival. Patients, it's a really big impact, especially for, females, younger patients. This is a big thing to not have hair loss. And in the end of the day, of course, it showed a survival benefit 2, 3 plus 7. So we do use this in the appropriate setting. I think the big challenge for CPX is how it fits, because this study was done in 60 to 75 year age population, people with therapy-related AML or AML-MDS-related changes. And of course, as you know, Venetoclax, even though it was above 75, there were people below 75 with comorbidities. And so how do you compete between Venetoclax and CPX? And there's a lot of discussion on this, and no clear mandate with the experts in the US having different opinions. But the bottom line is that this drug is available for secondary therapy-related AML. In fact, it's available in the US for all ages, even though the study was done only 60 to 75. The FDA said, well, biologically, everybody should be able to benefit. And so it's all ages. I think one of the things that has pushed many in favor of CPX, including, I think I was impressed by this data. This was an update by Jeff Lancet, published now in Blood Advances early 2021. But what they showed is among the people who got CPX and went to stem cell transplant, you can see that the 5-year survival was 56%. Now remember, these are really bad patients, right? You see a therapy-related AML, AML from MDS, AML deletion 5 and 7, and you're like, this is hopeless. But what they actually showed is, yes, with CPX and transplant, you could actually have a cure in a big proportion of these patients, and as opposed to 7+3, where you see 20%. So there's probably some unique biological activity here, and I think the drug is still worth considering in that secondary therapy-related AML, especially if you can transplant them. Without transplant, the benefit was not as high. But when you do CPX and transplant, then you really have a good effect. So now moving to something that I think in India, and I've got emails about this, so I know has caught a lot of attention, appropriately so. So this is doing, now we're going to talk about HMA-Venetoclax. You're all familiar with that, but Venetoclax is really a great potentiator. It's not restricted, and you'll hear this. So I showed you Venetoclax with IDH, AZA, doubles, AZA, IDH. I'll show you Venetoclax FLT3 data, Venetoclax FLAG-IDA. So it just is a powerful drug that synergizes with many, many different approaches in AML. So this is the FLAG-IDA Venetoclax. It's published now in JCO. The regimen has been modified. So for those of you who may be considering using it, I would recommend strongly to look at the paper, because the dosing is not the same as the Alan Burnett and MD Anderson original FLAG-IDA, because we tried it with the original full dose FLAG-IDA and we had a lot of myelosuppression, toxicity, sepsis. Luckily, patients didn't die, but this was with intense management, ICU at MD Anderson. Some of those easily could have died. So now we have cut down the cytarabine to 1.5 per meter square for 5 days, the IDA from 10 to 6 per meter square for 2 days, and the Venetoclax, most importantly, only 14 days. So those 3 modifications really change the whole tolerability of this approach, and it's become a much, much less myelosuppressive and better tolerable regimen. And of course, the reason we do all this is because we see this kind of activity and it's worth pursuing. So as you can see here in the relapse refractory AML, the second blue bar, we treat a true CR/CRi. These are not MLFSs. These are true CR/CRi with count recovery of close to 70%. This is something we have never seen with any salvage in AML, MEC, CLAG-M, whatever you may call it, 30, 35, 40% at best. But in a large population, about 40 patients, seeing this remission and quite durable, and it's translating into survival. So if you look at the right side curve, the people with relapse refractory AML, you can see that even in the 2-year point, there about 50% are staying alive. And especially with transplant, which is published in more detail in the JCO paper, we can get above 50% relapse refractory AML survival. So this is maybe the best regimen for a non-targetable relapse AML in our opinion today. FLT3 IDH, you can do well with the targeted therapies, but other than that, the FLAG-IDA Venetoclax is kind of our go-to regimen, except for TP53, and we will be publishing that data separately. TP53, FLAG-IDA Venetoclax is still not able to overcome, so we still need other approaches. Just to highlight, because I know this regimen is being used on a call I was in Europe a few days ago, a lot of people asked about this, Charlie Craddock and other colleagues. I really like to highlight that this is like the CAR T of AML for today, is how I would put it. It's highly intense. It is myelosuppressive. You need prophylactic antifungal, antibacterial. You need a big academic center. You need ID and ICU available. But if you do all that, you can get 70% people into remission, transplant, maybe cure up to 50% of those. So just like CAR T, a lot of intensive approaches, a lot of time and effort spent on these. But for our young 30, 35-year-old patient, totally worth it. And we're seeing some really amazing responses. But you have to know that there will be a component of neutropenia, myelosuppression, and transplant really should be ready to go within 4 to 6 weeks, so that once you clear the marrow, many of those are even MRD negative, but even if not MRD negative, move to transplant right away. And again, in second salvage, if you can do that, that's already half the battle won, and then you hope for benefit down the line. Now, moving from the intensive approaches to the HMA-based therapies, this is the HMA alone. You all know about that. Decitabine, azacitidine, single agent gave about 27% remission rate, 8 to 10 month survival. Still was better than the supportive care Hydrea approaches. And so they were approved and have been used for about 2 decades. But of course, efforts have been ongoing for those last 2 decades to improve them. Many different drugs have been developed in combination, Revlimid, Prasinostat, Peponidostat, Vocoroxin, more than a dozen. But the one that really stuck and showed great activity from the beginning, that's the other thing. A lot of people, this is something that of a soapbox for us at MD Anderson, people argue, you need randomized study, yes, maybe in the end, but you can tell. So Venetoclax, the first 10 patients we treated, literally the first 10 patients, 2014, we knew there was something unique about this. 9 out of 10 went in remission, 1 cycle, 7 were MRD negative. Yes, sure, then 800 other patients were enrolled, but you can really tell when something is clear. Now the Menin inhibitors are looking like that. You can really clearly tell that this is effective. And so after many years, the phase 1, the phase 2, eventually the phase 3 was done. This was in older patients, 75 years and above, or those below 75 with a clear comorbidity, cardiac, pulmonary, poor ECOG performance status, a lot of patients have this between 60 and 75, as you know, even in India. They will have some underlying severe comorbidity, very poorly controlled diabetes, renal dysfunction. So I would say between 60 to 75, almost 60% of our patients do fit into one of these, and we're usually going for HMA-Ven based approaches. And of course, the data here was confirmed, exactly what was seen in the phase 2 with the CR/CRI, again, true CR/CRI rates of 65 to 70%. The phase 2 showed about 70%, here was 66%, compared to AZA alone, which is quite interesting. Even the previous study, the randomized study that got AZA approval, showed 28% CR/CRI. And 10 years later, this study, again, AZA shows exactly the same 28% CR/CRI. So they really replicated everything that was expected for AZA and AZA-Ven. Survival benefit was also seen, 15 months versus 9 months. And that's good, but you can also see this as half full, half empty approach, where at the end of the day, at 1.5, 2 years, only about 35, 40% are alive. So for us, it's great because it used to be 10% and now it's 35, 40%. We're very happy. But if you tell a patient your median survival is 15 months and at 1.5 years, only 1/3 of people will be alive, few patients are going to get up and hug you and say, wow, this is amazing, right? So it's a good start, but I think, of course, we need to try to make this better and better. So moving into the management, and just like I talked about Venetoclax, this is true for every Venetoclax regimen, very effective, very powerful drug, but you have to be careful with myelosuppression, and it takes a little more effort than IDH and FLT3 inhibitors, more monitoring, more labs, more direct physician involvement. And here you see with the Venetoclax, as you can see, that the interruptions had to be done in almost 75 compared to 25% of patients because of neutropenia. And so you have to be aware that this is not a continuous therapy. Venetoclax almost never can be given continuously. We have to interrupt it, usually based on the end of cycle 1 marrow, to allow for count recovery. This is I will be sharing my slides. I'm happy to share them. This is probably one practical slide because I know HMA-Ven is being used a lot. This is the approach we use, and I would say 70-80% of academic centers are doing this approach as well, based on reviews and publications we have put out, where we mandate, and we really do this for all our patients at Anderson. We've treated about 250 frontline patients with HMA-Ven in different studies, end of cycle 1 marrow. That is critical because, and it's not just for response, it's really to know when you can stop Venetoclax without leading to prolonged cumulative neutropenia. So if the end of cycle 1 between day 21, 28 marrow shows either remission less than 5% or hypocellular insufficient marrow, means you wiped it out, there's no detectable clear leukemia, we stop Venetoclax. And that's probably the one single most important step to using HMA-Ven. Once we stop it, usually within about 2 weeks, most people spontaneously recover. We're checking labs, letting them recover, continuing prophylactic antibiotic, antifungal, antiviral. Some people even just waiting 2 weeks after the day 28 marrow, they don't recover on their own, we will then give Neupogen. You could give Neupogen earlier as well. Some people give it right after day 28. That's okay. But the point is stopping Venetoclax, allowing the neutrophil and platelets to recover before going to cycle number 2. So not doing continuously. Then cycle 2, we usually shorten the Venetoclax. Sometimes we'll do 21 days in that cycle, sometimes even 14. Let's say somebody took 50 days after cycle 1 to recover ANC. I would probably go just with 14 as long as they are in remission. And the other very important point is we strongly recommend use of prophylactic antifungal, antiviral, antibacterial, at least for the first 3, maybe 4 cycles, until you have a good rhythm and the neutrophil is stabilizing at above 0.5, above 1. And then you can, of course, stop these and then continue without prolonged neutropenia. So just talking a little bit about the biomarkers of response to HMA-Venetoclax, the point here really to make is that even though HMA-Venetoclax is effective across the board, it's more effective in some subsets like NPM1, IDH1, IDH2, splice mutations, where the responses are early, they're deep, they're maintained sometimes for years. Some patients are even cured, we're thinking, with this approach. At 4 or 5 years, we have NPM1 IDH patients in remission doing well without transplant. On the other hand, you have the bad actors, and this really includes 3 big groups: FLT3, TP53, and RAS mutation patients, where either the response rate itself is low or the responses are short and people relapse, and so we need better approaches. So talking a little about TP53, this is probably still the most difficult group. I gave a separate talk on this at Soho. For those who are interested, you can look at it. But effectively, intensive chemotherapy, HMA, HMA-Ven, CPX, nothing works in TP53. That's really the summary of bottom line. Here you see HMA-Ven response rates can be achieved up to 55%, but median survival is only 5 to 7 months, now confirmed in 3 studies, the phase 1b single arm HMA-Ven, the VIALE-A randomized, and even our MD Anderson DAC10-Ven, where we hoped that DAC10 will be special because there was data, as you know, in the New England from WashU, that DAC10 has some preferential activity in TP53. We did not see that with DAC10-Ven. Remission rates were good, but again, the survival was only 5 months. So we really don't think HMA-Ven is a breakthrough. Now, it's still better than HMA. Yes, remission rates are better. You can get them transplant, but it's not that much better, marginally improvement. So this is kind of where we're moving to some of the new therapies. CD47 antibody is one that we're very excited about. I personally have been working extensively on these trials. This is probably the first immunotherapy that seems to be showing a very good activity in acute myeloid leukemia. And the way it works is by unleashing macrophages. So by blocking CD47 SIRP alpha interaction on macrophages, you remove the inhibitory signals, macrophages are released, and they can attack leukemia. And azacitidine has a nice synergistic activity because in addition to blocking this don't eat me signal through CD47 SIRP alpha, azacitidine increases certain prophagocytic eat me markers. So you block the don't eat me signal, you increase the eat me prophagocytic markers like calreticulin, STAM7, and that is the preclinical synergy that's been published quite a few times by Ravi Majeti, Irv Weisman from Stanford. And this is the emerging clinical data, which looks quite impressive. As you can see, overall response rates actually close to what we see with HMA-Ven, 63, 65%, but especially in TP53, in fact, it's better than what we have seen with HMA-Ven with response rates of 70% and true CR rate of 45%. So again, this is single arm ongoing. We have to wait for randomized data sets, and even in the single arm, more prolonged follow-up because the follow-up was not long. But if this is true, then this could be hopefully a first improvement and breakthrough for TP53. This is a survival that was shown. It'll be updated in the near future, and you can see the median survival, especially in TP53, of greater than 12 months. But again, this is kind of early follow-up, but if this is confirmed with longer follow-up, I think we will all be quite excited about this data even before the randomized phase 3 is being read out. So this is the randomized phase 3. I don't think it's open in India. It's open in many countries in Asia, Europe, and US of Aza-Magro versus investigator choice, either Aza-Ven intensive chemo. So quite a unique study design. In fact, for the first time, we're going to not use fitness or age. It's going to be mutation selected. So anybody from 18 and above who has a TP53 could get either Aza-Magro or investigator choice. You want to give them intensive chemo? Okay. You want to give them Aza-Ven? Okay. And in fact, interestingly, the US FDA very appropriately supported this because they said TP53 does so poorly, it doesn't matter if he's a 30-year-old or a 70-year-old, they don't respond to intensive chemo HMA-Ven. So if Aza-Magro truly can improve outcomes, then we would just approve it across the age. And so we have to wait and see how that data goes. We are doing a triple regimen that there's a lot of excitement about. At MD Anderson, I'll be showing the data at ASH of Aza-Ven-Magro, very, very high response rates and MRD clearance. And we think this could be a good regimen, not just for TP53, but for all ages in the near future. A little bit about other immunotherapies that are emerging. There's a number of cellular therapies, more and more focus on innate immune system-based treatments through CD47 SIRP alpha. And you'll be hearing again in the near future a lot about NK cell-based therapies in AML. You know, it's already out there in lymphoma, but in AML, there's a lot of interest. Specifically, there's a drug from Fate Therapeutics that we've been working on, which is an NK cell high affinity, a non-CAR NK approach, which is showing high response rates. Again, early numbers, but it's showing responses in 5 out of 12 patients with second and third salvage. And so the study is very rapidly now expanded. But we think that this could be a very effective cellular approach for AML. And the nice thing is that since these are non-CAR off the shelf, they can be generated very, very quickly within a day or two, and they don't seem to have ICANS, CRS, immune cell effector toxicities. So we will see with more data. And then, of course, there are the traditional CAR Ts. CLL1 is becoming a target of more and more interest and preference. So we do have a multi-center CAR T study with Kite in CLL1, and there's a study in China with CLL1 in pediatric relapsed AML, where you see here early but very impressive response rate. So we'll have to wait and see. I'm going to skip this portion in the interest of time. This is the FLT3 data. I will mention that one of the things you will see in the FLT3 that we're very excited about is the Ven-Girt combo to be updated at ASH and published soon after that. And I know you have Venetoclax and gilteritinib approved. I would say that for any relapsed FLT3 AML in the US, at least MD Anderson, but I would say in almost all academic centers, because I've been on a lot of meetings, advisory boards, discussions, pretty much we've moved from single agent GILT to a combo of the ven gilt. Now, some argue ven gilt versus AZA ven gilt. I think the jury is still out. We are doing both those approaches. I think it's going to be hard to show the AZA adds much because you're already at 80% CRC rates, including 60% with molecular clearance. So these are not cosmetic remissions. These are deep remissions. Count recovery is an issue. So we have to use growth factors and ideally move these patients to transplant after 2 or 3 cycles. But I would strongly consider this, and I know a lot of people are starting to do this ex-US, and we're getting emails about how to optimally do it. But this is a very powerful combination and approach, which the NCCN is also reviewing potentially to consider in the future as a recommended approach. And then Frontline for FLT3, of course, building on that ven-gilt doublet in the relapse, can you, of course, now move it to do HMA-Ven, which is a standard, plus the FLT3, because as you know, in the FLT3 mutated HMA-Ven only gives a median survival of 11.5 months. It's not as good in the FLT3 as in the non-FLT3. And we're starting to see that adding a FLT3 inhibitor, whether it's gilteritinib or sorafenib, seems to really improve that remission, double this PCR and MRD clearance, and even the survival looks good. We'll be updating this as well at ASH. Numbers are so small, but now we're close to about 30 or so patients on the triplet, and the data seems to be holding true. And it seems that the triplet is really giving us very deep molecular MRD and actually is quite tolerable, again, in people who have experience with HMA-Ven and FLT3 and use the appropriate dose modifications that we have published on in some recent reviews. But now moving to the maintenance, which I'll spend 10 minutes on, because I think this is now emerging as a very, very important approach, both philosophically, because maintenance is now finally a part of the AML treatment paradigm. It was not, as you know, for the last 40 years, and also specifically because there is a drug called CC486 oral azacitidine formulation that has shown in a large 450 plus patient randomized phase 3 study a survival benefit when compared to placebo. Couple of very important things that I want to highlight about the Quasar study, and that's where we look at the inclusion-exclusion criteria. So these were patients above 55 years of age and patients who could not go to stem cell transplant. I think this is a very, very important point. This was not a study that randomized patients who could go to transplant and said, we will give CC486 versus transplant. That's a separate study, which is actually being planned and is an important study. But this study was people who were 55 years and above, had completed their planned induction consolidation. So let's say if there's just a physician said, I gave induction, I've given 3 consolidations, my routine practice in 2010 would be, I'm done because this patient either does not have a donor, he's too old, patient doesn't want transplant, he doesn't have the money, whatever reason, I cannot get him to transplant. So normally we would be done. But they said, okay, instead of being done, you'll get either CC486 or placebo and see how these people do. So I just want to caution, this is not a study that we should take people who have a donor, who are ready to go to transplant, have finished induction and got consolidation and say, you know, because I have CC486, I will do that instead of transplant. I don't think we have that data yet, and I'll show you why I say that. Even though the study was positive, and I think it's a great drug, and we are using it in our people who cannot go to transplant, this is not the same concept yet of maintenance in ALL. Remember, in ALL, when you do maintenance, you're talking about cure, right? So you've given them hyper-CVAD or pediatric regimen or hyper-CVAD now. You've achieved a remission, often MRD negative. You give them POMP for 3, or now we're moving it to 2 or 1 year because we're using antibodies, whatever it may be. And you know that 80%, 90% of those people are cured 5 years and beyond. So that is a true maintenance in a deep remission. Here, I would say this is almost like a prolonged consolidation. So you're separating the curves, you're improving survival 10, 12 months, which is great. But at the end of the day, at 4 years, you see that the curves come together. So this is not improving your long-term survival per se. And I think that's why we're still not ready to move away from transplant and do CC486. So in a patient who cannot get transplant for whatever reason, and there's a lot of those patients, especially in India, I know, but financial situation, comorbidities, not having support, family, logistics, whatever it may be, patient preferences, absolutely I would do CC486. But if they can go to transplant and you have a donor, I would still go to transplant today until those additional randomized studies are done looking at transplant versus CC486 and that confirms that CC486 could be as good. I don't even think it has to be better, but let's say it is as good as transplant, then yes, that could be an argument, but we don't have that data yet. The important thing is here that it didn't really matter what your baseline factors were, whether you had adverse cytogenetics, MRD positive or negative. This is important. Even MRD positive patients, they seem to benefit from CC486. In fact, there was a data presented in one of the subsets, I think it was Gail Robos who presented it, showed that 35% or 38% of people who got CC486 in fact became MRD negative. That's a little tricky. I don't like that number. The problem is everybody's using that number as the baseline for other trials. But if you look at that in detail, the placebo, 11% had MRD negative. And so nobody understands. And me and Gail and Andrew Way and others have talked about this a lot. And we think a lot of this has to do with sampling error, because why would a placebo 11% become MRD negative? This may be just which part of the marrow is sampled. But the point is, at least for survival, whether those were MRD positive or negative, the survival was similar. You could use CC486, whether it was a CR or CRI didn't matter. And most importantly, the number of consolidations didn't seem to matter as much. I would still be cautious on this because I've seen the actual numbers. They're very small. So my recommendation would still be do not dilute or do not reduce the number of consolidations. I would still do induction, do 3 or 4 if that's your practice, consolidation, and then go to CC486. Because if you look in detail, you do see that the people who got 3 or 4 consolidations, which was actually very few compared to those who got 0 or 1, there is actually a benefit. So if you do the proper full induction consolidation and then CC486, that's probably the best way. You don't want to subsidize or reduce your number of consolidations, hoping that CC486 will take care of it. You want to add it to your full standard consolidation. Sorry, here the slides didn't come out as well, but the point really here was that in NPM1 mutated, as well as in core binding factor, that's been looked at, CC486 actually really kind of improves your survival. Now, this may be an important subset where we don't routinely transplant these people, especially isolated NPM1 or core binding factor in remission. And so there, I would probably go on to CC486 because I don't routinely transplant those patients. But if our patient and if the physician wanted to do a little bit more, let's say the patient had a low level MRD or didn't achieve NPM1 clearance quickly, I think it would not be unreasonable to try CC486 there in those patients. So in summary, it was quite a well-tolerated drug, but you do see GI toxicity. I would say in practice, about 20-25% of the patients, we have to adjust the dose or duration of CC486 because of the GI toxicities. We usually go down from 14 to 10 or 7 days. So you have to be aware of that. Don't push it if the person is having severe diarrhea, nausea. It's expected. It happens in about 25%, and you adjust the dose, and it usually gets better. But beyond the GI, it's not very myelosuppressive. We do not see any major issues with neutropenia, prolonged cytopenia, infections. It is oral, so that's nice. Outpatient. We don't see any liver or hepatic. So all in all, I would say quite well tolerated patients for patients who have completed induction chemotherapy and consolidation. And that is now being reflected in the NCCN, where maintenance more and more is becoming part of the treatment paradigm. And of course, we think this is the beginning, CC486. As you may have seen already, there are trials ongoing with CC486 plus Venetoclax, CC486 plus FLT3, CC486 plus ID8, CC486 plus CD47, magrolimab, and TP53. And also I have to mention there is another oral HMA, which was not developed in maintenance, but is approved frontline in MDS called Aztec 727. This is oral decitabine. And this is also an excellent drug. Hopefully will come to India soon. And in the US, we're seeing a huge shift. 70-80% of our MDS patients are moving to Aztecs in the frontline setting. You can imagine, IV decitabine 5 days versus oral decitabine for 5 days. All the patients say oral if they can get the insurance to cover it, which it is because it's FDA approved in NCCN. So I think if oral Aztecs can become available, it's not a superiority argument. I would tell you it doesn't improve survival or anything compared to IV, but it's a convenience and an oral regimen. And so that's also being developed in AML, the oral Aztecs, both in maintenance, but even frontline Aztecs plus Ven. You can imagine in the future, 5 years from now, you get a FLT3 mutated 69-year-old patient, you can give them Aztecs, then gilteritinib. We're not there yet, but that's where we're moving towards developing oral therapy, monitor labs, amazing, right? Compared to what we did 5 years ago, high dose chemo plus transplant, all these things. So there is hope with these oral agents that things will move to a fully oral approach in the near future. And all these trials are moving very quickly and being developed. The last thing I just wanted to mention briefly is, and I'm not going to show the deep data on it because a lot of the data is not yet out there, it's embargoed, but this is really a very important group to look out for called the Menin inhibitors. As I said, there are 4 of them: Syndax, Cura, Daiichi, J&J, and actually a 5th opening. And this works through a pure epigenetic mechanism. So it's kind of like IDH1, 2, but instead of 2AG as the target, here the target is KMT2A, which interacts with Menin, which plays a major role in HOXA9 MEIS1 expression. And so by blocking this pathway, you downregulate HOXA9 MEIS1, which is very important to allow normal cell differentiation. And so guess what? The most common side effect you see with these drugs is differentiation syndrome, like you do with IDH1 and 2. But the differentiation syndrome with these drugs is a different level. It is very, very powerful and can be really aggressive, sometimes even dangerous. But that's actually, in the end, I think, a good thing, because it shows how powerful this pathway is. And at ASH, you will see updates with Syndax and Cura. And Syndax has already press released it. They showed in 40 patients, relapse refractory AML, 3rd and 4th salvage with MLL, 55% achieved CR/CRi, with 70% of those being MRD negative. And that's a single agent. And you know this will all go into combination, making it even better. So we think this is a real, a true pathway, an important pathway. Cura also has shown some very early data. It has less patients than Syndax, but quite encouraging. So in the end, I think this is a slide we had a year ago. It's already probably starting to get outdated. We need to add in the menin inhibitors for the future. Maybe cellular therapies will come here in the next few years. But for today, definitely for intensive therapy, I think there's 5 things one would like to know. APL, rule that out. Atraarsenic, core binding factor, addition of gemtuzumab. FLT3, add a FLT3 inhibitor, midostaurin today. Hopefully others like gilteritinib, quizartinib when the data comes in the future. And then CPX for therapy-related secondary AML. And for the last group, which does not have a targetable subset, we are going with FLAG-IDA, Venetoclax, or CLIA, Venetoclax. For the TP53, in fact, it doesn't seem to matter if they're older or younger. We are keeping those as a independent subset for which clinical trials should be prioritized. We hope the CD47s, based on the emerging data, will be an improvement that can then be further built upon. And then for older, HMA-Ven is still the standard, irrespective of the mutation. The question is it enough, especially for those TP53 FLT3, where the data is not as great with HMA-Ven, and how can we make it better? And a lot of efforts, and actually you'll see a lot of oral presentations on this, addition of IDH, addition of gilteritinib, addition of quizartinib, addition of magrolimab, and some of these are starting to look more and more impressive over time. Transplant, as I said, has not gone away. In fact, for older patients, even with HMA-Ven, because we actually get 70% in remission as compared to 25%, and a lot of them start feeling better after remission, even though they were frail. After 2-3 cycles, their counts are better, they feel stronger. So we're actually transplanting more older patients today than any time in the past, up to 20-25% compared to 10-12% historically. So transplant has not gone away. In AML, it's still very much there. But maybe in the future with cellular therapies and others, we can modify how we are doing the transplant or even avoid it in some patients. And then maintenance, I think now is a critical part of the whole treatment total therapy paradigm, whether it's after intensive chemo without transplant, people who cannot go to transplant, or whether it's after transplant. In fact, there is a study, I didn't show it here, but the UK group, Charlie Craddock and others are doing a big study called Amadeus study, which is going to look at CC486 versus placebo post-transplant. So of course, if that's positive, then that will get a post-transplant approval for CC486. Today, already FLT3 inhibitors post-transplant, I would say, are a standard of care approach that I would recommend to use. So a lot of things happening. And of course, you have my email and feel free to contact me anytime. And I'll turn it back to Dr. Agarwal and the team. Thank you.
Beautiful update. I mean, we have been listening to you so many times. Still, every time there is so much new data, and the whole way you put it up, it's very, very different. Thank you so much. Before I invite all the guys who are here and the question from the question box, there are a lot of questions people have asked me to tell you and have an answer about this oral azacitidine. Mainly, they want to know whether this is a replacement for injectable azacitidine. That means wherever they are using injectable azacitidine, can they use oral?
Yeah, so the answer is absolutely not. And that's actually, I should have shown a slide on that. So it's very important to note that the IV azacitidine gives you a PK of about 30 to 35%. I'm sorry, oral azacitidine gives you about 30 to 35% of IV azacitidine. So it gives you a much lower free azacitidine level in the blood. In fact, we think that may be one of the reasons it was so well tolerated and could be given for 2 years in maintenance, is that you're giving such a lower amount of azacitidine. But of course, one can imagine that that could be dangerous in a frontline setting if you're giving only 30, 35% azacitidine with Venetoclax and suddenly our response rates drop to 40, 50%, it could dilute the therapy. So today, we are not using it in any setting outside of the maintenance. However, there are trials looking at that approach. So CC486 plus Venetoclax, CC486 plus FLT3, all of these things, both in active disease and maintenance. But today, yeah, that's the one thing, even from community doctors, we get a lot of questions. We say, do not use that as a replacement, only for now in the maintenance.
The second question is about its dose, 200 versus 300. That's another confusion.
Yeah, I think if you look at the, and then something I don't completely remember off the top of my head, but I think most of the data has been with the 200 dose for 14 days. And I think that's how it was done in the randomized study. There is the option to increase it to the 300 for people who have MRD positivity, or even increase it to 21 days. So that could be considered. But I would say that when we went to the 300, and this was many years ago, Garcia Monero from our group did the study, the myelosuppression and toxicity started coming pretty quickly. So our approach today is still the 200 for 14 days, which I think is the label dosing, and then increase it if we're seeing disease progression or MRD increase or blast increase.
The third question is, there is MD Anderson study about the low risk MDS, where this was used and there was some mortality because of the neutropenia. So the people are asking whether if the WBC count is okay, if the neutrophils are okay, is a transfusion dependent low risk MDS, whether oral azacitidine can be used.
Yeah, that's that was actually the I just mentioned exactly the Garcia Monero study, and I think it was a dosing issue, and I don't remember in detail. This study was done many years ago. It was published recently. It was done many years ago. If I recall, I think we were using 300 for either 21 or 28 days. It was a more prolonged schedule, and we think that may have played into the toxicity to some extent. I personally, we are not using oral azacitidine MDS in the frontline setting. And one of the reasons is because the Aztec 727 oral decitabine actually got a full label approval specifically in that subset, where oral decitabine versus IV decitabine in the phase 2 study, they showed exactly the same PK, 99% PK equivalency, and similar response rate and efficacy. So if we go for a normal formulation MDS in the US today, oral decitabine is what we're using. I don't know the answer to that question. I guess you could try it at the lower dose. I still would be nervous, so I would probably stick with IV azacitidine. Yeah.
Thank you. Dr. Neeraj, go ahead.
Thank you, sir. Thank you, Dr. Dava, for that excellent, informative talk. My question is on, minimal residual disease measurement. What is the algorithm that you use? Do you use flow cytometry, multiparametric flow cytometry, or NGS? And how do you make decisions based on, do you make decisions based on post-induction minimal residual disease status?
Yeah, no, it's a great question. I mean, that's probably a whole talk on itself. But to make it, so one, we use flow. That's our still the most trusted MRD for us at MD Anderson. We are starting to do more and more NGS. In fact, just last week, we had a lot of discussion with our molecular pathologists, and they're hoping in the next 6 months to go to a higher sensitivity, 0.001 NGS for some of the markers, FLT3 and DM1 others. So when that comes, probably, use NGS. How we use it is with flow, usually in the intensive chemo setting, where we're using it. We're not using it much in HMA-Ven setting. But with intensive chemo, if somebody is not flow MRD negative after 2 or 3 cycles of intensive chemo, we would go to transplant, irrespective of their risk, whether they were intermediate or favorable, we would consider transplant. The second way we're using it is to direct therapy. And I think this is what you'll hear more and more in the next few years is, people who have a FLT3 that's still detectable, let's say after intensive chemo, they got 3+7 MIDO, we may switch them to Ven-Gilt, and the same for IDH. In fact, there's a very large study you'll hear about in the next year called the Intercept study that Andrew Way from Australia, myself, Courtney Donardo, Marina Konopleva, Paresh Vyas are working on, which is going to build a full MRD platform with high sensitivity, single cell analysis of targetable MRD. And we'll have 8 arms in that study to target each. FLT3 will get Ven-Gilt, NPM1 will get HMA-Ven, MLL will get MLL inhibitor. So that's the future, is to do molecular MRD and then target, not just say MRD positive, negative, let's do something, but say FLT3 MRD positive, IDH MRD positive, TP53 MRD positive, NPM1. And now we have the tools to actually target that MRD in the combo. So long answer, but today I think it's the intensive chemo setting for transplant, but a few years from now, I think it will actually guide our combinations.
Thank you. Thank you very much.
I request those people who are not speaking, can they mute yourself? There is a lot of background noise from their home. Okay. Ranjit? Unmute yourself, Ranjit.
That was a very excellent, Dr. Naval. My first question is, how do you manage patients who are both NPM1 as well as FLT3 TKD mutant at your center? Do you still add midostaurin, and what is the role of adding a FLT3 inhibitor in such cases?
Yeah, so actually that it's a simple answer. We treat all FLT3 as FLT3. In fact, there was a paper in AJH, Dr. Musa Yilmaz's first author, I'm the last author. We looked at this subset of what we quote unquote the ELN calls favorable NPM1 mutated with low FLT3 allelic burden. And even in those who had very low FLT3, less than 0.1, with or without a co-occurring NPM1, the addition of FLT3 inhibitor and transplant seemed to have a survival benefit. So today, our practice, and all of MD Anderson, we all agree, is any FLT3 mutated patient, irrespective of NPM or not, we're adding FLT3 inhibitor. And actually, that was shown in the midostaurin study that addition of FLT3 inhibitor improved outcome with low and high FLT3 allelic burden, and we're going for transplant. There's debate on this. A lot of people feel that way. There are some who may consider not doing transplant. I think if you have a high sensitivity NPM1, which is even in Anderson, we don't have it routinely, and I think it'll be maybe hard in some places in India. But if you have a high sensitivity NPM1, as the Australians and UK do, and you can show that you get NPM1 eradication after 1 or 2 cycles, and they have a low FLT3, you may consider not doing transplant. But today, to be safe, I would do FLT3 inhibitor and transplant for any FLT3 mutated.
For TKD especially, NPM1 and FLT3 TKD.
Well, that's rare. So that's rare. So NPM1 FLT3 TKD, I don't think we looked at that specific subset. I would still probably do the FLT3 inhibitor and transplant, but I think that's a little bit more tricky because you're really more of an isolated NPM1. So yeah, if the NPM1 cleared out, your MRD became negative, it's a 60-year-old, 65-year-old donor is haplo, I may not do transplant, right? It's a 30-year-old, has a max sibling donor, everything is good, I may. So that's kind of a personalized decision. I don't think there's hard data for NPM1 TKD.
I have several more, but I would ask after everyone is complete.
Thank you.
Thank you. Thank you, Ranjit. Bhavin?
Yeah. Excellent talk, Dr. Naval. And most of the molecule which you have described is not available, but Venetoclax somehow we can able to procure it. Now in patients with intermediate and high risk group, whether we can add Venetoclax along with 7+3 combination, is there any data available, and what is your recommendation for that?
Yeah, so there is ongoing study with Rich Stone, and it's open at MD Anderson, Marina Konopleva, and me as well, of 3+7 Venetoclax. Very early, we had some problems with that, the dosing, where there was issues in the number of days and things. So there was some early toxicity mortality. My answer would be, if you want to use Venetoclax with intensive chemo, use flag Venetoclax, because there's good data published in JCO, reputed, 2 years we have the experience with it. I'm much more comfortable doing that than adding Ven to 3+7, where for some reason we're seeing more toxicities and we're working on that regimen. So I would say flag Ven is the better approach for today with data.
Fine. Thank you.
Thank you, Bhavin. Ramaswamy?
Yeah, excellent lecture as usual, Naval. Thanks. My question is just a brief guess. 30-year-old man, good risk, cytogenetics, inversion 3 with 7q, band 11, 11.11.3 and 33 deletion. 7q deletion with 16 inversion 16, and had 7+3 regimen. Post inductions, MRD 5.4, marrow aspirations diluted 4 to 6% blast, biopsy scattered, few blast cells are seen. Molecular was 0.017. Because of the MRD, flow MRD, he has received another 7+3 reinduction. Post second 7+3, MRD molecular was 0.012 and flow MRD was 0.3. Now, being a good risk, whether to proceed with the consolidation, because from the first post-induction he was in molecular remission, or because of the flow MRD was positive in the post-induction as well as the post-reinduction, even though it is a good risk to proceed with the transplant. You mentioned it to Dr. Neeraj answered that 2 to 3 cycle flow was a consistent parameter for you. But being in this good favorable risk, what should be done? So you mentioned 2 to 3 cycles. Now I have given a 2 cycles, flow MRD 0.2. Please go.
So I think I missed some of there was static. He has a deletion 7 and an inversion 3. In addition,
it's not deletion 7. It is a 7q band 11.3. Yeah, exactly, with inversion 16.
Inversion 16. So yeah, I think for this patient, I would probably lean more towards transplant. You have flow MRD positive after 2. So there's 2 approaches. This is probably what we would do. We would probably give him 1 cycle of flag gemtuzumab at this point. That's what I would do. If you could get gemtuzumab, or flag venetoclax if you cannot get gemtuzumab. And then I would do a bone marrow and see. If you do get, clearly less than 0.1 on flow and you get, PCR clearance, things are going the right way, then you could continue with 2-3 cycles flag ven and then maybe put them on maintenance. If you don't, after really intensive therapy, 7+3 is not really, so I would go for the real intense, flag ven, flag go, see if you achieve a deep remission, then no transplant. If you still have any MRD positive after flag ven or flag go, I would go to transplant.
Thank you.
Thank you. Dr. Prashant.
Thank you, sir. It was a fantastic lecture. And I think days are not far ahead, when we will write another editorial that, death of 7.7+3, the way it is going. So
I think Dr. Kantarjan already wrote a couple on those. You'll see him soon. That's what he's been waiting for 40 years. So yes.
So my question is basically with the newer molecules, Ven and midostaurin and all. So what is your antifungal prophylaxis is like? The azoles have a lot of drug interactions. So is it liposomal amphotericin B or you still go with the azoles?
No, we still go with azoles. The lipoembosome is very logistically difficult and coming to the hospital every other day or every day. So we still do azoles. The 2 azoles that have been the most powerful at preventing fungal breakthrough have been posaconazole, voriconazole. The third one, which one could use, it's a little bit less powerful, but it's still probably good enough, is isobuconazole. So we usually prefer posaconazole or vori, and the main drug that has to be adjusted, as you mentioned, is venetoclax. Most of the FLT3 inhibitors are okay. Midostaurin, there's some data that you may want to reduce it, although it's not clear. But yeah, we do 100% of the patients azole prophylaxis, usually limited for about 2-3 months until they're in a good remission, counts are good. And in fact, for venetoclax, and I know many countries are doing this, it's actually a economic argument. So I know in Australia, they actually use azoles for everybody because it's cheaper to get azole than do 50 or 100 of ven than 400 of ven, right? So you give vori, posa, and then you give 100 of ven, and it's cheaper. So this may be true in India as well, especially if you have some generic azole versions where you could actually not have to give full doses of ven.
So it's a valid option.
Thank you.
Thank you.
Yeah, thank you very much, Dr. Naval, for that very comprehensive presentation on AML. And it's now obvious that we are having more and more molecules to fight AML. However, I'm getting a little bit confused as well, I would say. And so I would just restrict to one question, which is what is the precise role of gemtuzumab, both upfront as well as relapsed? Because previously we used to use it, then we shunned it, and now it has been reinvented. So which are the situations where you would use it?
Yeah. So don't worry about we're confused too. We discuss this every week in our meeting. We have 4 meetings, 4 hours, and we discuss, and you'll see we all disagree. Ravandi, Kantaraj, and me, there are things we're still working on. But it's in process. So gemtuzumab actually is the easier question. So yeah, I think absolutely gemtuzumab has a role in core binding factor AML. That is the one subset where we continue to use it. 100% of our core binding factor frontline, below 75 years of age, we do intensive chemo. Flag is our choice with gemtuzumab. You could do even 3+7. Gemtuzumab data is pretty good. So that's the one subset I would use gemtuzumab. We do not use gemtuzumab for the non-core binding. That's where we're doing Flag-Ven or FLT3 with Flag or CLIA. We don't use it in older populations. We're doing HMA-Ven backbones. We don't use it in salvage, although the FDA has approved it. The data is very soft, 20% remission rates. It's not worth it, we feel. So core binding factor intensive chemo gemtuzumab is the only real area we're using it.
Thank you.
Thank you. Dr. Naval, I know you have to go. Let me know if you have another 4 or 5 minutes.
Yeah, we could do maybe another 2 questions, and then I have to run, take my son to soccer. So yeah.
Ranjit one, Ramaswamy one, and that's the end of it. Yeah.
Okay. So my question is, how do you manage the NUP98 and NSD1 rearranged AML, which has got a FLT3 mutation positive? How do you manage it?
That is a really good question. We're actually just writing a review. You guys are like on top of things. So we're just working on this data set of NUP and with or without FLT3, but really the NUP rearranged. And actually, I think that a lot of our panels have been missing this because, as you know, you need a specific fusion panel to pick up the NUP translocations. You don't pick it up normally on the routine FISH. So we actually think that the incidence could be as high as 5 to 8% based on some of the new fusion panels that pick up NUP214 and NUP98 and other fusions. So the Menin inhibitors really work really well in this group because they actually do upregulate MEIS1 and HOXA, the NUP translocations, and we're actually putting a lot of patients on the Menin inhibitor trials. And what's actually interesting is that the Menin inhibitors have very high synergy with FLT3 inhibitor. You'll see a paper coming out in Blood from Kampala's group, from our group, showing synergy between Menin inhibitors and Venetoclax and Menin inhibitors and FLT3. So today, I would probably do a FLT3 inhibitor as a standard of care. It seems to still work. But tomorrow, meaning like in the future, a few years from now, we think Menin plus FLT3 could be curative in this NUP with FLT3. But it's a great question and a very interesting area of research for us.
Thank you.
Ramaswamy, can I have Dr. Hasmukh before you? I forgot that here. Yeah, Hasmukh, please.
We can do 2, no problem. Yeah.
Thank you, Dr. Naval, for such a nice informative lecture. My question is for FLT3 mutated case. When will you start midostaurin post-transplant, and how long you continue it?
So I will say our favorite has not been midostaurin post-transplant. As you know, the RADIUS data was not clearly positive where sorafenib has been. So if you had the option, and I don't know any of the access, but I'll probably go more towards sorafenib, and I would try to start it between day 45 and 60 is ideal, but up to 90 is fine. Even if you start after 90, it's still good. But the goal is 45 to 90. And sometimes you cannot do it because of GVHD, you start it later. But 45 to 90, and then sorafenib, if you have it, is my choice. Start 200, maybe twice a day or even once a day per month, and then slowly go up to 400, 200, 400, 400 if tolerated. Most people don't tolerate more than 200 BID. Midostaurin would be the same approach. If that's the one that's available, you want to do it between 45 to 90 days. The earlier, the better, but at least when the GVHD is down to grade 1 or lower.
And how long you will continue it?
Oh, that's a great question. So yeah, I would say off the top of our head right now, we don't have randomized data. It will come from the BMTCT and gilteritinib randomized study, but 2 years is kind of what we're doing. But I would say that, I have patients who at 2 years and they're doing really well. I have some young patients that are in college, some are working, they take the pill and they say, is there any risk of stopping? I said, there's always some risk. They say, well, I'm just going to continue, doctor. If they have insurance and access, very few people at 1 or 2 years want to stop it because they're already over all their side effects and are doing well. So 2 years is kind of what we say is rule of thumb, but if the patient is happy in continuing it, we just continue it.
Okay, thank you.
One last question, Ramaswamy.
Yeah. So just one question is IDOS-Arasi consolidation. There is a, as you are aware, everybody knows 3 gram per meter square, 1.5 to 2 gram per meter square. What is your carry home message? Europe, American, 3 gram per meter square and 1.5 to 2 gram. Your expertise comment.
I couldn't get some of the question, it cut off.
What is the optimal dose of high-dose RSA, basically, he is asking.
Oh,
Consolidation. Consolidation.
Consolidation, yeah. So MD Anderson, as you know, we don't use the HIDAC as consolidation. We're doing the FLAG-IDA or the CLIA, so FLAG-IDA is its own consolidation, right? And in that we use 1 gram per meter square. I think more and more from the other experts, I talked to Marty Town and others who do use it, I think most people have moved to 1.5. Very few are still using the 3 gram. So I would say 1.5 is kind of what's being used in the US with 3+7.
Thank you. I think now we have stretched you enough. I don't want to. Now my commitment to you was 90 minutes and I will not stretch you. So thank you so much. Others are free to put an email to him and I'm sure he will reply. So
Absolutely.
questions in the question box and all those raised hands still over there. Please forgive me. Okay, and official vote of thanks from Ashish.
Thank you. We at Zydus sincerely thanks MHG and Dr. MB Agarwal for giving us this opportunity for supporting such an insightful scientific event. I thank Dr. Naval for his great session today and through his talk showing the future direction in AML treatment. Through his lecture, his clear future of AML holds more hope and is very, very exciting. Thanks to all the faculty for the wonderful discussion and not to forget our respected virtual delegates who joined us today evening. I once again thank Professor Dr. M. Agarwal for his untiring efforts to create such platforms to improve the hematology care in our country. Good night for now, and I also wish Happy Diwali as our festive season is approaching fast. And I also hope and wish we don't have a COVID rise post Diwali. So stay safe, take care, and good night for now.
Bye-bye. Bye, everybody.
Bye-bye.